everyone. My name is Haley Buckner, and I'm the Professional Relations Manager for Elevate Oral Care. Thank you for joining us this evening. Before we start, I'd like to cover a few housekeeping items. For those of you who remain online past 50 minutes, your CE certificate will be emailed within hours of the completion of this talk. Be sure to check your spam folder. You are all muted, so there is no need to worry about background noise. We will have time at the end for questions, and you can submit those questions on your webinar dashboard, and we'll track those throughout the talk. We have hosted an extensive series of free live CE webinars on many prevention topics. Each of these webinars were recorded and are available with free self-instruction CE at elevateoralcare.com/elevatingcare. Bookmark this page and return often to see what's new in free CE. If you have a topic you would like to see covered, feel free to suggest it by sending an email to info@elevateoralcare.com or by completing the webinar survey that will be sent after the completion of the talk this evening. We enjoy looking through your suggestions and creating webinars based upon your requests. And that's exactly how we came to this evening's webinar with Dr. Leslie P. Lang. We continue to field requests for webinars on silver diamine fluoride, and Dr. Leslie Lang is going to dive in how silver diamine fluoride can be beneficial for patients who are suffering from Sjögren's disease. So it's my honor to introduce you all to Dr. Leslie P. Lang. As a clinical associate and former assistant professor in the Department of Prosthodontics at the Faculty of Dentistry, University of Toronto, Dr. Leslie Lang holds a joint prosthodontic and dry mouth specialty position at Toronto Public Health Dental and Oral Care Clinics, where in the past 4 years, she has delivered over 600 dentures to low-income seniors. She also has private practices in Toronto, Mississauga, and Brockville devoted to implant and prosthodontic dentistry. At each of these practices, she has established Sjögren's disease dry mouth resource centers and continues to conduct research projects on various aspects of Sjögren's disease and other causes of dry mouth. She was awarded the Queen's Toronto Alumni Branch Tricolor Championship Award in 2020 and the Queen's University Alumni Association Global Citizenship Award, formerly known as the Humanitarian Award, in 2022. She is honored to be the current president of the Sjögren Society of Canada, co-chair of its medical advisory board, and member of its board of directors. So, Dr. Lang, without further ado, I'm going to turn it over to you.
Thank you so much, Haley, for introducing me. This is a true delight for me to be here and to speak to you about the black magic and Sjögren's disease. So who am I? Just to recap then. So I am the president of the Sjögren Society of Canada. I am the co-chair of our medical advisory board, as well as member of our board of directors. I'm a clinical associate researcher and lecturer at the Faculty of Dentistry, University of Toronto. I am both a prosthodontist and an immunologist in Toronto at the public health clinics, as well as in private practice throughout the province of Ontario, in Toronto, Mississauga, and my hometown of Brockville. I have no financial relationships with ineligible companies to disclose. I do not have Sjögren's. Nobody in my family have had Sjögren's. None of my friends had Sjögren's. But when I was in grad school learning all about immunology and autoimmune diseases, I thought, now there's a disease that sounds as though it needs a voice. So years later, after I became a dentist and then a prosthodontist, that's where I devoted a lot of my research studies. And a prosthodontist, by the way, in case you don't know, is a dental specialist who replaces usually missing teeth, but also eyes, ears, noses, palates. We're working on brains, but we're not quite there yet. All right, so the objectives for today's course would be to introduce to you the invisibility as well as the conundrums associated with Sjögren's disease. We're going to try to gain an understanding of the extent of the oral debilitation of Sjögren's and also the challenges that there are in treatment. And I'm also going to, for some fun, introduce to you some black magic to manage the dental deterioration. Now, I'd also like to introduce to you some of my family, my canine family. So these are the salivating setters, or my Celtic collection. The white ones are the English setters, the red one at the back is the Irish setter, and the black and tan is the Gordon or the Scottish setter. And all I have to do is to say treats, and I can get a mass of saliva being released. And saliva, unfortunately, is, it's not something that we as humans can put on or turn off the way we can with dogs. And it certainly doesn't get a very good reputation. In fact, the terms that are used to describe or nickname saliva are very derogatory, such as spit, slobber, drool, spittle, dribble. But it unfortunately leaves a lot to be desired with respect to all the benefits that saliva can give to us. It certainly preserves and maintains our oral health as well as the function. It aids in digestion. And I remember when I used to teach high school biology, when we were learning about the digestive system, we would give the students a dry cracker. And I would tell them, now put it in your mouth, start chewing away, but try not to swallow. Well, within a few seconds, most of them would actually have the whole cracker dissolved just from the enzymes that are present in the saliva. It also contributes to taste perception, facilitates communication, and protects our oral tissues from desiccation, microbial penetration, as well as ulceration. And it will certainly stimulate some soft tissue repair. And I would be quite remiss if, as a prosthodontist, if I didn't mention a little bit about something to do with prosthodontics. It certainly provides comfort while wearing dentures by means of its lubricating ability. Also, it will protect the dental surfaces, and with our saliva, it will act as a neutralizer, particularly to acids, or act as a buffer, and it will in turn promote remineralization. But just in the words of one of our famous Canadian singers, that of Joni Mitchell, you don't know what you've got until it's gone. And when it's gone, you would tend to get dry mouth. But let me assure you that dry mouth is not the same as thirst. So for example, if you were thirsty, you could drink a glass of water and that would be the end of it in most cases. But instead, dry mouth comes up with 3 different terms, of which I'd like to just define these. So the term that is used most frequently is that of xerostomia, when in fact, this is the subjective sensation that their mouth is dry. It's the patient's perception. So I may look in their mouth, and even though they've told me that their mouth is dry, I may see quite a lot of saliva there. But that is one sensation, and that's the true term of xerostomia. It's their perception that the mouth is dry. Then we get another term, such as the salivary gland hypofunction. And this is an objective measure of decreased saliva secretion. So in other words, below normal. And we look at this by looking at the salivary flow rate. And there are 2 ways that we can do this. One is referred to as either unstimulated or arresting saliva. And this would be a case where you would be asked as a patient to actually lean over a funnel, which would go into a test tube usually. And every minute, over a 5-minute period, you would be asked to just allow the saliva to dribble into the funnel and therefore into the test tube. And with Sjögren's patients, this is very difficult to do because quite often we don't get anything. This is different than the stimulated saliva, where we would ask a patient to chew on either a piece of gum or maybe unsweetened gum, which is known as gum base, or even a piece of wax. And this is stimulated. So this is mechanical stimulation of the saliva. But if you have a diagnosis then when the saliva secretion becomes pathologically low as measured by objective measures, then this is what is known as hyposalivation. But unfortunately, as I mentioned before, xerostomia seems to be the more professional term, and that's why you would see that quite often, and yet it's incorrectly given, because that is the patient's perception the mouth is dry. So dry mouth then is associated not only with Sjögren's disease, but also many other autoimmune disorders such as lupus, scleroderma, diabetes, even graft versus host disease, and also rheumatoid arthritis, as well as primary biliary cholangitis, which used to be known as primary biliary, oh shit, no, I can't remember the name of it. Cirrhosis, sorry. And cirrhosis, unfortunately, is seeming to be associated with alcoholism, but this was completely different. And so the name has been changed to cholangitis. Also, there are patients who are being treated for head and neck cancer therapy who can have dry mouth. And this situation of dry mouth is completely different, both in quantity and quality in comparison to Sjögren's, in that many of these cancer patients will have perfectly fine salivary gland release up into a stage, and then it's almost as though a tap has been shut off. And sometimes this may actually turn back on a few months later after the therapy, but not in all cases. There are also anywhere from 500 to 800 common everyday therapeutic medications, such as the statins, blood pressure medications, anti-anxiety medications, and so on. And certainly in Canada, a few years ago, the smoking of marijuana was considered legal. So now we even have patients who smoke marijuana complaining of cottonmouth with the use of marijuana. So that's another way that we can have dry mouth. So now let's look at Sjögren's disease. It's a systemic autoimmune disease that's characterized by the lymphocytic infiltration and dysfunction of several of the exocrine glands. The primary ones are the lacrimal or the tear glands, as well as the salivary glands. Now I'm hoping my pointer can show this, but in your cheeks are the large parotid glands. And these are the ones that release the aquatic or aqueous amount of saliva into the mouth. Then at the corners of the jaw, you would have another pair of glands known as the submandibular ones, and they, as well as the other pair of major glands known as the sublingual ones, are the two major pairs that produce the mucus part of saliva. So together then, those three major pairs of salivary glands are the ones that contribute primarily to our saliva. But you can also see that there are minor salivary glands, and these are on the tongue, known as the lingual glands. There are ones in your lips, known as the labial glands, as well as ones on the palate, or the palatal glands. Now, a little bit of new information for you is that in 2021, some of the Dutch investigators were trying to find a shield so that some of their cancer patients would be that would normally be subjected to having their salivary glands ablated by the radiotherapy. They wanted to see if they could prevent that from happening in the cancer patients. And in this study, they had over 200 patients that were involved, and they did some of the study was included by having some bioluminescent targets that would light up the salivary glands. And you can see in these four diagrams just the positions of where the major salivary glands are located. But unbeknownst to them beforehand, the patients all came up with two new string-like glands that kept showing up in all the patients. And you can see where the blue arrows are in A, that they're long, thin, they're in the middle of the head, both in between where your ears are and certainly in between the front and the back of your head, but within the skull, which is why they would not be seen if you looked intraorally. And you can see indeed just where these are located. Now, it's my theory that because these are mucus secreting glands, that this may actually be the reason why many patients get post-nasal drip. And if you remember your anatomy, you will remember that there is the fovea palatini in the palate. And certainly in my dental school, we were taught that those holes may be the area where mucus is released, but they're also the markers as to where the back of a denture is located. Well, maybe the creator actually was a prosthodontist. I mean, that's what we were taught in grad school, but certainly there's got to be another reason as to why those openings are there. And so it's my thought that these tubarial glands, as they are now known, that may be the reason why we have secretions or post-nasal drip. So it's my hope that we will be able to study these in the Sjögren's patients. So who was Sjögren? Well, Sjögren was a Swedish ophthalmologist who, in his private practice, had noticed that there were several patients who were reporting to him and complaining of dry eyes. And in his investigations with these patients, it was noted that not only did they have dry eyes, but they also complained of dry mouth, as well as joint pain, and that they were all females. So in his thesis that was published in 1933, this was the first publication about this, but it was not considered very important at the time at his university, and unfortunately he didn't get tenure through this. I kind of know the same story, but I will mention, just to show you now how recognized this is becoming, and July 23rd is the birth date of Sjögren, and this upcoming July 23rd in 2025 will actually be the 16th annual World Sjögren's Day. So it is becoming known worldwide, but very, very slowly. So the hallmark features of Sjögren's are, as I mentioned, dry eyes, dry mouth, overall fatigue, as well as joint pain. And yet I must mention here that there are about 60 other features that one could have, although fortunately no one has all those symptoms. And the reason being is that there are even those patients who tear constantly, as well as those who will drool. So obviously you can't have a dry mouth and drool at the same time. So this diagram is taken from one of the brochures that we have at the Sjögren Society of Canada, just showing you a few of the ways in which Sjögren's disease can affect your body. So not only can you have the 4 hallmark symptoms that I've just mentioned, but you can have swollen salivary glands, you can have what's known as brain fog, constant nosebleeds, difficulty speaking, eating, chewing, swallowing, therefore making it more difficult to digest your food. There is estimated to be up to a 35% increase in lymphomas. There are lung problems, increased rates of bronchitis and pneumonia, liver problems, as I've mentioned before, with cholangitis, even active hepatitis, extreme fatigue, vaginal dryness, Raynaud's phenomena, where you would have a white fingers that are icy cold, as well as peripheral neuropathy. Sjögren's disease affects mainly postmenopausal women, and it's usually in a ratio of 9 females to 1 male, and that's my representative in this photographic montage here. So there's the 1 male against the 9 females, and you even have a version where it would affect children. So imagine the poor boy who is 16, who is now suggested that he has Sjögren's disease. Certainly not in common. Sjögren's disease, then, just to give you a few statistics, there are more individuals with Sjögren's than if you add up the numbers with scleroderma, lupus, and multiple sclerosis combined. And yet many have never heard of Sjögren's before. And I'll use some Canadian statistics here, but in Canada, there are about 22,000 Canadians with scleroderma, about 50,000 with lupus, about 90,000 with MS, and yet there are about 430,000 Canadians, or 0.5 to 1% of the population. Now in the United States, put zeros onto all these to get the equivalent. And Sjögren's is actually only second to rheumatoid arthritis, yet everyone seems to know what that is. And when COVID came along, of course, we kept hearing about how many nurses there were. And in Canada, it was estimated that there were about 400,000. So therefore, there are even more Sjögren's patients than there are nurses in Canada. All right, so what are some of the challenges that are associated with this disease? Well, first of all, it's the weird name. And you can see the spelling S-J-O umlaut. Now, how does one pronounce that? Well, in English, we seem to pronounce it as Sjögrens. In other words, you're showing some smiles. My apologies to any of you who are of Swedish background, because you would say, well, that's not how you pronounce it. It's more like a Sjögrens, which I can't say very well, but in English, we say Sjögrens. The other challenge is that it is not curable. It's not preventable right now. It may be prevented at some time in the future, but we can't delay it either. It frequently goes unrecognized, it's overlooked, it's misdiagnosed as though it's not serious, and quite often it will take anywhere from 3 to 9 years to become diagnosed. The other challenge is how to treat dental decay. So if we were to Google an image of Sjögren's, this was one of the first patients that you might see. And this was taken actually before privacy laws came about. But I have blackened out her eyes. Now, is this Sjögren's disease? Well, of course it is. But you can see that if every Sjögren's patient had bilaterally swollen, not only parotid glands, but submandibular glands, as this lady did, it would be very easy to recognize that. So no, not everybody has swollen glands like that. But in fact, this is Sjögren's. Now there's a very attractive female. How would you know that she had Sjögren's? Here's another one. I wonder if you recognize who this is. This is our one and only celebrity, Venus Williams. You may have seen her on some eye remedy commercials a few years ago, but now she has let it be known that she does indeed have Sjögren's. So she's our one celebrity, as far as I know, who has Sjögren's. There are also numerous classification criteria. Now, this is a little bit different than the diagnosis, but if you were to enter into a clinical trial as a Sjögren's patient, you would need to undergo a specific classification criteria for the pharmaceutical companies. In most cases, they like to just focus on one disease at a time and not get distracted, if I can call it that, with another disease. So since 1965, there have been 13 different classification criteria alone, 3 of them since 2002, and one of them that was published in 2012 didn't even include oral symptoms, which of course is just heresy as far as I'm concerned. So even more confusing is that the disease was originally known as Sjögren's syndrome, or even without the apostrophe S. About 2 years ago, we in the international community who are on a working group to look into Sjögren's disease have now decided to call it Sjögren's disease as opposed to syndrome, which gives it a little bit more weight to indicate how serious this disease is. We used to also classify it as primary or secondary, not because Sjögren's took a second fiddle to any other autoimmune disease, but if you only had the one, I say only in quotation marks, if you had just Sjögren's disease, it was known as primary Sjögren's. But if you happen to have another autoimmune disease or another connective tissue disease, then Sjögren's was given the classification as secondary. It didn't mean it took a back seat to the other autoimmune disease. It just meant that it was in conjunction with. The Canadian organization is known as the Sjögren's Society of Canada. The American one is known as the Sjögren's Foundation. And I've put in just again a little plug for the Canadian one there, and there's our logo. This was the latest classification criteria that was written in or published in 2017. It's the latest one that there is. And you can see at that time it was still using the term primary and Sjögren's syndrome. So again, this was meant just for those who had Sjögren's alone and not complicated with another autoimmune disease. So just to show you what this is like, is that the criteria was based on having a blood test done. And the antigen and antibody set that were looked at in the blood was that known as anti-SSA, or looking for an antigen known as Rho, after one of the first Sjögren's patients. And if you happen to test positive for this particular antibody, this was given a weight of 3. Now, you may be familiar with this, that there is another antibody known as SSB, or the La, and we find now that there are not as many Sjögren's patients with this one. So that is why it is that the SSB or La is not included in this particular classification criteria. There's another set of tests that pertain to the eye, and one is with a material known as lissamine green, which looks at the staining of the eye, and this stains for surface irregularities. You can see the one on the left has a lot of grains, and this is with the Sjögren's patient who has very severe dry eye disease, whereas the one to its right, you see it's not quite as granular, but again, it is another Sjögren's patient with some maybe less or fewer surface irregularities. There's another test then looking at the amount of tears that can be produced over a 5-minute period. And this is a piece of litmus paper that has graduations on it. So if you cannot produce less than 5 millimeters in a 5-minute period in at least one eye, you get a weight of 1. And the surface irregularity stainings also gets a score of 1. Now here's the unstimulated saliva test that I was explaining to you a bit earlier, where you lean over into a funnel which goes into a test tube, and every minute over a 5-minute period, saliva is collected. Well, because the Sjögren's patients tend to have more mucousy saliva, it's quite often that saliva that's collected is stuck in either the funnel or even the test tube. So if the unstimulated salivary flow rate is less than 0.1 mils per minute, that also gets a weight of 1. We can also use the Schirmer test with the graduated piece of litmus paper and measure that way as well. But as I say, the weight is strictly 1. Now, a slightly more controversial test is to see if you actually have a focus score of lymphocytes. And this is done with a minor salivary gland lip biopsy. And you can see here in the lip where the slice has been made, and you can see the minor salivary glands here. And when they are removed, this is what it would look like and the size of them. And if these glands are then subjected to an eosin dye and looked at under the microscope, you will see that there may be a cluster of lymphocytes in one area. And this is known as a focus score. So just like you would have a flock of geese, you would have a focus of lymphocytes. So if there are at least one focus within a 4 square millimeter surface area, this gets a weight of 3. All right, so now that's a lot of our mathematics. So if you add up all the weights and the score is at least 4, then that patient then meets the criteria for primary Sjögren's at the time, Sjögren's syndrome at the time. Okay, let's look at some more gruesome photos, if you will. Pardon this for those who are squeamish, but let's look now at the oral consequences that are associated with the dry mouth. So first of all, as I mentioned, there is the hyposalivation or low salivary flow rate. There's altered salivary composition that will reduce the buffering capacity, the antimicrobial capabilities, as well as the ability to clear food from your mouth and in turn bacteria. And you can see as you look closely at this photograph, this patient already has some restorative work in the form of some gold crowns on the molars. You can see there's some recession here, a lot of cracks in the teeth and so on. And you can just start to see some bubbles and mucus-like saliva present. And this is when I first met this lady who has Sjögren's. She was a nurse, so she was very familiar with the disease itself. She lived outside of Toronto, about an hour's drive away, and she would come to see me about every 3 months. So moving along then, as time goes by, you can see that, yes, some of the teeth would start to break off. And she had no pain with this. You can see that they break off right at the gum line. You can see that there's a lot more plaque. There's a lot more mucus around the tissues. Some of these are swollen. Look at how dry her lips are. So quite often the soft tissue will be ulcerated. But you can see, and this is what came home to me as having been trained as a microbiologist. Yes, we know that strep mutans is usually the main culprit with respect to decay. but it didn't make sense to me that in a mouth that is very dry, which is therefore more acidic, that this would be a good environment for strep mutans. So yes, it may be present, but it's certainly not the main culprit for the decay that happens, because the decay pattern is completely different. So we actually did a study looking at the bacteria that are associated with Sjögren's and came up with 4 new bacteria. Now I'm going to leave that as a bit of a lingering thought for the moment, and we'll get back to that a bit later. But you can see then that as time went on, that there's rampant tooth decay, frequent deterioration of the dental restorations that you're trying as a dentist to keep up with. There's increased tooth loss. And also, this is a wonderful environment for yeast. Now, we all have yeast in our mouth, but in a dry and therefore more acidic mouth, these patients are very prone to yeast infections, what is also known as thrush. So let's just look at the recap then. This again is the same lady. You can see the crowns that she's had in the posterior. And I should suggest to you as well that you may say, well, okay, let's put in crowns and that will help maintain the teeth. Well, it does to some extent, but just remember where the decay occurs. It's at the gingival margins, and that's the one place where crowns will not cover. As time goes by, you can see the swelling of the tissues. You can see even here, there's the molar that was on the crown teeth. There's the root canal remnants. So even a crown tooth can break off. And as a prosthodontist, I was trying to keep up with her. I made a little flipper to replace this missing tooth. The next time she came back, more teeth were broken off. You can see the teeth even split like this, to the point where then finally several teeth were lost in the mandibular arch. And again, no pain. Whereas if somebody without Sjögren's had teeth that would break off like that, there would be a considerable amount of discomfort. Now here's another patient who this is her graduation picture when she was in her 20s, lovely smile. But when she was first referred to me by a periodontist, this is the way she came. No pain associated with this, but she worked in a hospital and she said she was a receptionist and she didn't want to have her dentition look like this anymore. So as a prosthodontist, what we do is to take photographs and also make impressions, so we can have models to see what the patient is like when they're not in our office. She also lived out of town. She came back 3 weeks later, and already you can see more teeth are broken off, more pieces of the teeth are broken off, and again, no pain at all. Now, she was lost to me for about 5 years, mainly because she was taking care of her mom who'd had stomach cancer. But when this patient came back to me, this was the state that she was in. So you can see again just how many teeth have broken off. But she said now that mom had passed away, it was time for her to look after her own situation. So we'll see her again a bit later on. So you may say, well, why then don't we just put in some implants? Because that way it's going to be, the implants don't get decayed. So let's look and see if that's going to be the answer. This was one of the first studies that was done with respect to implant prosthesis and that of Sjögren's. And you can see the name is still with Sjögren's syndrome. And there are 2 points here that I highlight in the abstract. One is the first sentence, that implant-supported prostheses offer a solution to the patients. And secondly, that patients often find it very difficult, if not impossible, to wear conventional complete dentures. Now, if you remember back in your prosthodontic days, what's one of the first things you tell your patient who is now going to have a denture for the very first time, whether it's a flipper with one tooth missing or a conventional denture, is that because the denture is sitting on the soft tissues, then there's going to be more saliva being stimulated. Well, the same is true with these patients. Now, in this particular case, the implants were placed way back in 1987. And I know this is a long time ago, but nonetheless, this is one of the very first papers that was published about the implants in Sjögren's, and it's still referred to in all the systematic reviews. So the patient was the lady with the bilaterally swollen glands that we showed you earlier. And she had, in May 1987, Brandemark implants placed, 6 of them in the maxilla, 6 in the mandible. And when she came back in the October of the same year, she had already lost 1 implant in the maxilla, 1 in the mandible. And this is even before any impressions were made. So in this particular paper, which is an 8-year follow-up, you can see that there another implant has been lost. And this is a photo to show you this wonderful success of this provides an optimal solution for the Sjögren's patient. Well, if you count the implants, she's now down to 4 in the maxilla. She still has 5 in the mandible, but you can even see the threads of the implants. And you're telling me that that's a success? I don't think so. And many patients have been referred to me over the years with Sjögren's. This is one where this was a celebrity who had her own TV show back in the 80s. And she said, well, I don't really like the shape of these teeth. Can you take it out and fix it? So we took it out and she said, well, yeah, I've got a little bit of a sore in my left-hand side. And lo and behold, the implant comes out. Later on, here's another implant that comes out. So now she's left with 3 implants. She can't have a fixed prosthesis anymore. These are some of the other implants that you can see that are on their way out, that if the patient sneezed, maybe these would fall out. Here's another one. This was a man who had lost 3 implants. Well, we knew they were coming out. In fact, this is his panoramic. You can see that these are the 3 implants that came out. And this poor gentleman actually went through having 13 implants lost over time. He just kept going back and saying, no, I want fixed solution. And unfortunately, the surgeon kept making him pay for this. I never really got much of a chance to make any kind of prosthesis for him. Here's another patient who had multiple implants placed. This is at University of Toronto for the mandible and McGill University in Montreal for the maxilla. So you can see she's already lost an implant in the maxilla, 2 of them in the mandible over time. Again, these implants are just holding in with a thread. So I did a study, a radiographic study, to look at these implants. Are they good? And I looked at 24 patients with 123 implants versus 3 times as many non-Sjögren's patients, just to make sure this wasn't biased. And if you look at the survival rate, it's very comparable. But if you look at the success rate, which was listed under Albrechtsen and Zarb's classification, that there cannot be more than 0.2 millimeters of bone loss per year, you can see there's a huge difference. And this was just on a radiographic study. Now, if it was just a single tooth implant, maybe there would be a better prognosis, but certainly with a whole a full mouth series, then the implants may not survive. But I don't want to be the bearer of doom and gloom. As I mentioned already, that maybe before you consider having implants placed, maybe something that is removable and more conservative will actually stimulate saliva. And there have been several studies over the years that will vouch for that. But if a patient does lose an implant or even more, but at least 1 implant is remaining, it's possible that you could change that to a locator attachment. This would be the inside of a denture with the attachments, and have a very lovely solution using any remaining implants that would be present. And this is functional as well as aesthetic. Now, okay, let's switch gears a little bit here now. So this was a paper that came out in the Journal of the American Dental Association in 2016, showing how wonderful, supposedly, fluoride is for caries management. And I ask you, just do a little test, if you will, and look at more than just the abstract. And you will find that the evidence actually for fluoride in caries management is actually lacking. So here's my food for thought. When Sjögren's patients who've been using highly fluoridated rinses daily, as well as concentrated fluoride paste in specialized trays, and have undergone fluoride varnish treatments every 3 months and still have rampant decay and crumbling teeth, is the fluoride effective on its own, or are the decay-causing bacteria still thriving? Well, that was my thought, because many patients have been referred to me to say, Leslie, please look after these Sjögren's patients. And so it didn't make sense to me. It's almost as though the fluoride is there on a treadmill. It's running its little heart out, but it's getting nowhere fast. So this is now where we get to the stage of our black magic. And I didn't use the actual music from Santana because it was too much for copyright laws. But just think of black magic and that will be your earworm for the day. So let's look at this silver as it is here now. So if we go back in time, Hippocrates was considered to be the father of medicine. And you will look back at his time where he would use silver within wound care. Silver has also been used in dentistry way back in 659 in China for its antimicrobial effects. Silver was used in wound healing in some of the dressings during the world wars, and we still put silver drops into newborn babies' eyes who were delivered vaginally. So the caries management, if we look at the medical model of this, just remember that caries is not a single lesion, but it's actually a continuum of disease by a bacterial infection. And patients are at different degrees of risk. And yes, we as dentists were all taught to use a drill, but that is a surgical model. And having a microbiology background, you cannot drill your way out of a bacterial disease, because even if you leave 1 or 2 bacterial cells around, they can reproduce. So the more contemporary caries management philosophy is one of a medical model. And this is going to now include both the use of a antimicrobial agent as well as the fluoride therapy as a partnership. So here comes now the 38% silver diamine fluoride, or SDF, which has been suggested to be used for a minimally invasive treatment for dentin hypersensitivity as well as carious lesions. And this is the way it first came out. It was a blue liquid, looked like blue water that you would apply with a microbrush. And it has not only silver in it, about 25%, which is the antibacterial part. It has 5% fluoride, which once the bacteria are dead, then this allows the teeth to be remineralized. It has a blue dye, so you can actually see where you are applying it, and has a pH of 10. These are the forms that the liquid version would come in, and nowadays we also have the newer version with a gel, which also stays on the tooth a little bit better than the liquid version does, and it's less likely to be spilled. Okay, so when SDF became licensed in Canada in 2017, I jumped on it because I wanted to do some studies with my Sjögren's patients, and I'll explain why in just a second. But what we would do is that you isolate the teeth with cotton rolls. And in my study with the Sjögren's patients, I only looked at the posterior teeth to start with because I was scared stiff that it was going to turn the teeth completely black. And I didn't want these patients leaving with black teeth. So I started out by looking at, let's say, the lower right quadrant and upper left quadrant, and then 2 weeks later, minimally, the patients would come back, and I noticed that if there were any areas of blackness, that these were actually now hard. And then I would apply the SDF to the opposite side, so the upper right and the lower left. And I would do this on a 3 or a 6 month follow-up time. Now, the silver diamine fluoride indications for use were for extreme caries risk. Now, here's that term, xerostomia, but we've all learned from tonight it should be hyposalivation. But as I say, xerostomia sounds more professional, if you will, or more serious. But it also is for severe early childhood caries. Now, remember I said that we had done a microbiology study to look at four new, and found that there were four new bacteria that were associated with the patients with Sjögren's. And one of those species of bacteria happened to be the same one that is evident in the severe early childhood caries. So that is why it was of interest to me when the studies were being published from the University of California in San Francisco. Now, I'm just going to put a little bit of a plug in here because as I mentioned at the beginning that I still work, I work 2 days a week at Toronto Public Health. And I started there right before COVID started. I was to actually insert my first denture March 16th, 2020, which was the day that all the clinics in Toronto and Ontario closed down because of COVID. But about 2 months later, Toronto Public Health managers called me back and said, would you like to continue working? We want one clinic office to be open during COVID. And I said, sure, I'd love to. So back we went. And do you know that the silver diamine fluoride kept our patients out of sensitivity issues, kept them with the anti-caries control, so we didn't need to do any drilling because of the aerosol technique, but it kept our patients going throughout COVID. So again, I say hats off to Silver Diamine for getting us through COVID in Toronto Public Health. But now let's just look. Okay, so here's the one of the weird bacteria, Scardovia wigsii, and this is the one that is associated with severe early childhood caries. This is what a child with the childhood caries looks like. And you can see that the decay pattern is very similar to that of what it is in the Sjögren's patients. In other words, it's at the gingival margins and it's on the smooth surfaces rather than interproximally or on the occlusal surfaces. And here is a child who has had the SDF treatment. Now, yes, you can say that that doesn't look very pretty, but with either the application on the same day of glass ionomer, or if you want to do the composite resins, just make sure that you do it on a day other than when you apply the SDF, because as soon as you cure the composite resins, there will be a grayish tinge. So don't make that mistake. But to show you now what some of the Sjögren's patients look like here is one with SDF applied. Here are some broken down teeth, and you can just see how black they are. You can see that the decay is also occurring at the gingival margins, particularly on the premolars. These teeth were going to be extracted, but with the SDF, we're now decreasing some of the bacteria that are involved. To make it a slightly healthier situation when the teeth are extracted, if that's going to be the case. Okay, and here's another example then. You can see at the premolars where the decay is shown, but this is the same patient as the one on the left, and you can see that thanks to the little bit of saliva that the sublingual glands are releasing, that there was no decay at all on the lingual surfaces, only on the buccal surfaces of her lower teeth. The other thing I wanted to mention here is that this lovely named bacteria, Scardovia, has now been recently isolated in not only the gut microbiota, but also the feces of patients with Sjögren's. So you can see that this is present throughout the digestive system of patients with Sjögren's. And here were some of the study results where I've done, well, over 80 Sjögren's patients have been involved. And this would, on the top left, you can see where I'm just about to apply some of the SDF. You can see it's stained the cotton roll a bit. And just a few minutes later, you can see where the decay is and the black that has shown up. The interesting part about putting it into the Sjögren's patients is that the saliva is stimulated. It's almost as though the brain is saying, yuck, this tastes awful, so let's get rid of it. So it's a saliva stimulant for these patients. But it also turns their saliva white for the few minutes when you first apply it. This is another patient, and you can see this was a 30-year-old, and you can see almost every single tooth that she had when she was treated by her former dentist, that there are decay patterns here. But the point of this is that all the patients who had said anything about sensitivity, the sensitivity had now completely disappeared within a few days. That any areas that were soft beforehand when I would touch this with a probe were now hard in as quickly as a week. And as well, what was so wonderful about this is that these patients could now undergo some bonding treatment for cosmetic purposes. So here's the case where you can see some of the SDF staining, and now you can see how the teeth are being treated with a composite resin. Looks perfectly acceptable and is now acceptable by insurance purposes. Here's the same lady, as I mentioned before, who was in her 30s, and it was as though her dentist had heard Sjögren's, ka-ching, and her radiographs to me looked as though she didn't need all those fillings, but every single tooth had a filling on it. And so we treated this with some composite resins and gave her quite a lovely smile afterwards. Now, there are those, again, some of my pros patients who have Sjögren's, and you can see that, yes, we can treat the teeth that are normally would be extracted, but if we put the SDF on, it will halt the decay and maintain the roots so that the bone levels can be maintained. And if you've ever extracted a tooth from a Sjögren's patient, they're very difficult to extract because oftentimes the roots will just crumble. So here's a case where we applied the SDF to the root stumps, gave her a set of a partial denture, and a beautiful result. And she'd had one implant before, which was not successful, which was before she met me. But here is now some prosthesis that not only will give her a functional result, an aesthetic result, but also will stimulate saliva. So then in conclusion, something you can see is I'm very passionate about, but you can see that Sjögren's disease is a very serious systemic disease. With many severe oral consequences, not in all patients, but in many of them, that we can use some very easy to use techniques, not only to moisturize the mouth, which is another seminar on its own, before we resort to pharmacological intervention, but by using the SDF application, we can see that it will indeed arrest the decay that previously plagued these patients, and with minimal invasion and inexpensive treatment, that we can give them some aesthetic results that are finally achievable and give them not only their self-esteem back again, but provide them with optimistic oral health. So my hats off to the Silver Diamine Fluoride. It is my black magic. So something we would all like with the Sjögren's patients. Thank you so much for listening. You can tell how passionate I am about this, but if you would like to email me, there's my personal email address. So thank you so much for your listening.